Hi, I'm Brian Gruber, founder of Integrated Orthopedics, and today we're going to talk about non-operative treatment of joint pain. The orthopedics obviously is the treatment of bones, muscles, and joints. Joint pain is exceedingly common in our practice. We see the knees, shoulders, hips daily, specifically for only pain in the joint. The large joints are very commonly affected, so the shoulders, the hips, the knees, the ankles. We also bring up the medium-sized joints, so the ankles, the elbows, and wrists. We also see a fair amount of pain there as well. And you will see joint pain in the hands from arthritis, the small joints of the hands, as well as the feet. The number one reason for joint pain would be osteoarthritis. That's the most common reason that someone might come to an orthopedic surgeon for joint pain. Of course, you have trauma. So if somebody twists their knee and injures their cruciate ligament or maybe a meniscal tear, those patients would also typically have joint pain. So you can have sort of the traumatic treatments, such as the twisting injury to a knee or a direct hit to the shoulder, versus the natural aging process, which would be arthritis, which we can see as early as the early 30s. And you can also have autoimmune causes of joint pain. For example, lupus, rheumatoid arthritis, Sjogren's disease. There are many non-orthopedic, if you will, more rheumatologic reasons that someone may have joint pain. So typically in a joint pain setting, we want to figure out a diagnosis. So we'll do that initially by x-ray. We have on-site x-ray here. For example, say somebody has arthritis. There are many conservative treatments consisting of lifestyle modification, anti-inflammatories taken orally, ibuprofen, naproxen, injection therapies, and we have many different shots that we're doing, steroid injections, viscosupplementation, Toradol injections, as well as the biologics, PRP, and stem cells. For the arthritic situation, we'll stay on that. We do send folks out for a knee replacement surgery. This is clearly the last alternative and the last option, and we do exhaust all conservative treatments, and we can with the appropriate treatments, we can delay or prevent knee replacement for many years. Oftentimes patients will come in and they'll have joint pain, and there will be a component of deconditioning, and that's where physical therapy can be very beneficial. For example, patients may come in and they may have a swollen joint, and the swelling on the knee causes the quadriceps muscle, or the muscle in the thigh, to atrophy or shrink, and that alone can be a reason why the patient has joint pain that may be somewhat magnified. So a common approach would be to get the joint settled down, and there are many different ways that we can do that. Anti-inflammatories for one, steroid injection would be another example. We'll get the knee swelling down, get the pain down, and then we'll get the patient into some physical therapy to work on strengthening. And then when it's all said and done, the goal really is to have a better functioning joint that has significantly decreased pain, and it's something that can be long lasting. Yeah, we see patients, they become kind of the integrated family, where we see them, a couple times a year or possibly more frequently. However, it's fun when you see patients and, you haven't seen them for 3 or 4 years, and maybe it's for a different body part. Maybe you treated them for their knee, you injected their knee, and they're fine, and they come in for their shoulder, or maybe they come in with their significant other. So, some of these treatments can definitely be long lasting. With arthritis, the typical non-impact activity is recommended, and it's always a challenging conversation, specifically to have, like, say, with a runner who's done that lifelong. Oftentimes those folks don't want to decrease their running. However, sometimes the body will make us do things that we don't exactly want to do. What we really try to do is have some sort of a blend. For example, somebody's running 5 nights a week and they're having a lot of knee pain. Maybe we'll say, cut down the mileage, or maybe instead of running 5 nights a week, you cut that down to 2 nights a week. So you're not having to completely disengage from what you enjoy doing, however, modify Some of the other activities that we would like to implement would be biking, swimming, elliptical, and things that are really just non-impact, that are good for your joints, that are good to keep your legs strong, get good cardiovascular workouts, however you're not having a significant impact on the knees. So joint pain typically should not last longer than 2 weeks, so if that's something that continues, and really at the same intensity. So you may still have some joint pain, but say it started out as an 8 out of 10, hypothetically, that should be decreasing over the 2-week period. It shouldn't stay at an 8. That would be something that you should be evaluated. Swelling of the joint is not normal really at any age, so that's something that should be evaluated sooner than later. Loss of motion is also something that can signify some more significant underlying pathology. I would say the important thing of coming to the surgeon's office is the majority of patients that we see are treated non-surgically. So if you come to the office, you're really looking. The vast majority of people just need a conservative treatment plan, be it just activity modification, anti-inflammatories, topical anti-inflammatories, injection therapies, physical therapy, bracing. That's the hallmark of what we all as surgeons do. Even though we are surgeons, we do treat the majority of our issues non-surgically.